Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. Namaste Adab. How are you? Hope all of you are fine and well and sound. As you know, today, inshallah, we are going to discuss some questions regarding gynecology module and surgery module also. So Allah be with us. Okay, I need you to be cooperative, please, and quick, so that we can take as much questions as we can. Yeah, let's start with the first question. Okay, I'm going to minimize it a little bit so that you can see the whole options. I think this is good. Okay, I need your answers. What do you think? And I'm so sorry for those who are going to hear the recording. I'm not well enough to read all the questions. I'm so sorry. So you have to have a look on the screen. Okay, so most of you agreed. You can maximize it from your phone, like you maximize any picture. But if I maximize it more, you are not going to see the options. Okay, as you can see, guys, this woman is having a very important risk factor. You got it. I know you got it. Which is, yes, the history of a DVTE in her cuff following a fractured femur as a result of an accident 10 years ago. Yes, exactly. And this is why I'm not going to think of a systemic route of estrogen alone. Okay, let's see, or let's take it step by step. To prescribe the correct HRT, first you need to know what? Her age. Okay, is she above 50 or below 50? Number two, does she have a uterus or not? They said her uterus is intact. Right? Okay. Number three, does she have any other risk factors? So that I'm not going to prescribe her estrogen only, HRT, specifically speaking, a systemic one. Okay, the woman here cannot sleep and she's having hot flushes. So she needs estrogen. Meanwhile, she's having history of VTE. So as most of you have said, the most safe one, the safest one within the options is what? The transdermal continuous combined HRT. Excellent. Okay, if I told you that the uterus was removed in hysterectomy 2 years ago, and forget about the options, what would be the best for her? If there is no uterus, transdermal estrogen only. Excellent, Dr. Aisha. Yes, excellent. And please don't say estrogen generally. She still have the factor of the VTE, so I'm not going to give it to her orally. Transdermal is very safe. Yes, excellent. Transdermal estrogen is very, very safe. Okay, you got this one. Excellent, guys. Okay, let's take another one. Here. I'm also going to mark the risk factors. This patient is having abdominal distension. She's having low abdominal pain, urgency. She's 55. Abdominal examination is unremarkable. The urine dipstick is negative. Okay, I know this one is tricky and I love this question, by the way. So it's very easy, but really tricky. First of all, most of you have thought about that she could be having an ovarian problem, right? Or a uterine problem, maybe. Right? The dipstick is negative, so we excluded the UTI. Abdominal examination is unremarkable. So even if you still suspect that there is a pelvic pathology, in the NHS, we don't do the pelvic ultrasound at the first step, by the way. We don't do it. So think about it again. If you are suspecting ovarian problem or a malignancy, because this woman is having distension and pain and so on, which one of those would be your first line investigation? The CA125. Yeah, not the pelvic ultrasound. But guess what? This patient is not risky. She's not risky. With the information in our hands now, she's just having abdominal distension and some pain and some urgency. See, this is really, really important because the abdominal examination is unremarkable. And they didn't mention anything about weight loss or bleeding. Okay, so up to this point, this patient does not need anything. Guys, think about it in general. So we are going to perform the serum CA125 and pelvic ultrasound for all ladies who are having some distension and lower abdominal pain. No way. This is why I love this question. You are thinking with the mentality of a gynecologist. And you should know when to perform the investigation and refer the patient for ultrasound. So number one, we don't do the ultrasound as first line investigation. In the NHS, when you are suspecting a postmenopausal woman with signs and symptoms suggestive for ovarian cancer, serum CA125 is going to be the first thing that you are going to order. Okay, here we are. This is from the guideline, and because none of you answered it correctly, I want you to have a look on the explanation. Bloating, yes, it's a sign of ovarian cancer, or a symptom, sorry. Loss of appetite, feeling full quickly, pain in the abdominal pelvic area, urgency, more often than usual, unexplained tiredness, weight loss, changes in the bowel habit is a very important symptom. Okay, if you are having those more than 12 times a month, or it have been for a while, it's over a month, you should offer CA125. This is not me or my opinion, okay? This is the RCOG advice and the NICE guideline advice. And we don't do this routinely, okay? There is a huge difference. We don't do this routinely. We only do it for those who are highly suspected to have ovarian mass. And of course, if she's having ovarian problem, usually this is going to be diagnosed very late. Not all patients are having symptoms, by the way, but at least you should have this. The duration, the progression, the weight loss, okay? the changes in bowels. She's going to have constipation, then diarrhea, or diarrhea for a long time. And the GIT doctors and the GP have tried many things with her and it's not resolving. It's going to be like this. Okay, but not from the first presentation. This is what I mean. Okay, what do you think about the upcoming one? What would be the recommended test for the biochemical detection of hyperandrogenism? Also, this is according to the guideline. You might think that, oh my God, all of them can be done. And this is why MRCOG is tricky, because they want you to answer according to the GTG. So according to the GTG, which one is the best one, the most sensitive one for the detection of hyperandrogenism? Yes, free androgen index. Yes, hands together to everyone who said free androgen index. We can offer free testosterone. Yes, we can offer total testosterone. Yes, but still, even after you are going to offer those, you still are going to recommend free androgen index. In case those are raised, are going to confirm hyperandrogenism by the free androgen index. So free androgen index, as I told you, this is a question that I also love, is a recommended test, the most sensitive one. This one is using the total testosterone divided by the sex hormone binding globulin. What else you are going to need? It gives you a clear image if this woman is really having hyperandrogenism or not. Okay, this is something like anemia. Are you going to offer ferritin or the iron binding globulin or the total iron? So which one is most sensitive? Which one you would recommend? I don't know why I'm asking you this, but it just popped in my mind that they are similar. Yes, exactly, the serum ferritin. The serum ferritin. And if you are going to, or you want to know if this is a consuming anemia, that the patient is not taking the anemia, okay, it's a problem of consumption, or she's losing the iron. What's going to help you find out? The binding globulin. Okay, the same. Okay, if it's a hemorrhagic anemia, I mean, or a problem with the absorption. Okay, so let me ask you, I'm not sure if there is a question about it or not. Sure, I'm having one. We can return to the algorithm. Okay, who have read the talk article regarding endometriosis and infertility? Anyone have an idea about this? Okay, I'm getting mixed answers. Okay, the most important factor impacting live birth rate. Okay, not whether the patient is going to have a successful operation or a successful ART. We are talking about live birth rate. So this is different, by the way. Think about it. There is a huge difference. We have factors that impact live birth rate and factors that impact the successful rate of the IVF or ICSI. Okay, only few of you got it. Only few of you. This would be female age and number of oocyte vitrified. The live birth rate, guys, is affected by the female age, okay? Because the older the female, the poor the quality of the oocyte. Even if you got a successful cycle, it could lead to miscarriage, early miscarriage, okay? Or chromosomal anomalies. So the numbers of oocyte is going to increase your chance for having a successful cycle. The female age is going to increase the chance for having a successful live birth rate. This was mentioned exactly like this in the talk article. This one, what is the single most important factor in determining female reproductive outcome in general? Okay, I'm still having different answers, so let's see. It's a female age. Female age mainly. I just told you. I just told you the female age. Okay, yeah. The single most important factor in determining reproductive outcome, whether she's going to have a spontaneous conceiving or ART, IVF or ICSI or whatever, they all depend on her age. Okay. Need something about, yeah, HMB. So what do you think about this one? So you are between conservative management or laparoscopic myomectomy or what? Hysteroscopic myomectomy. So you can do hysteroscopic myomectomy for intramural fibroid. How you are going to do this? Okay, first of all, we are having a woman who is having 3 intramural fibroids. Each is 2 centimeters in diameter. She wished to start her family very soon. Anyone remind me, please, if you are having fibroid less than 3 centimeters, are you going to think about surgical management? No. No, we are thinking about surgical management if we are having fibroids more than 3 centimeters. So here you can go for conservative management only. Conservative management means medical management. Myrina, okay? They make it, by the way, here it's a little bit tricky because you are expecting to see Myrina in the options. But guess what? The woman wished to start her family very soon. Even if Myrina is here, it's not the correct answer. What would be the most appropriate treatment for this lady? Tranexamic acid, yes. Or non-steroidals, this or this. Yeah, and no, not COC. She wished to start her family very soon. Right? Okay. Again, first of all, I'm not going to offer her surgical management. She is having only 2 centimeters fibroid. Okay. Number two, she can go for conservative management. Conservative management means medical management. She wished to start her family very soon. Can you prescribe her Myrina? No, Myrina needs at least 6 months to work. So it's not like I'm going to insert it and remove it. It's not working this way. You need 6 months for Myrina to control the bleeding. Okay, so got it? Okay, got it? So we are between tranexamic acid and mefenamic acid. That's it. We don't have any other choices. And not COC, of course, because this woman wished to start her family very soon. One of the famous recalls, by the way. Okay, you know, when should we perform a physical examination prior to commencing treatment for HMB or heavy menstrual bleeding? Only one condition. Only one condition in which you should perform physical examination prior to commencing medical treatment. Otherwise, GPs are always prescribing medication for patients with HMB without even doing physical examination. C, yes, when Myrina is being considered as a treatment option. Yes, yes, guys, it's not about the amount of bleeding. It's not about her history, nothing. Okay, who can remember what would be the basic investigation that you are going to offer to all patients with HMB? Excellent, CBC. Yes, and nothing else. Thyroid function is only offered to those who are having thyroid symptoms. Coagulation profile is offered to those who are having HMB since menarche, or they are having a bleeding or a blood disorder in the family, but not all of them. The thing that you are going to offer to all ladies is CBC, definitely. Okay, what would be the indication for histological biopsy in a 45-year-old woman presenting with regular heavy menstrual bleeding to secondary care? This woman is a perimenopausal woman. Okay, and she's having regular heavy menstrual bleeding. So what would be the indication for a biopsy? This is not a routine thing. If there is what? Okay, 7 mm thick on the ultrasound scan is not hyperplasia. This is one. Okay, number two, we don't offer biopsy for those who are having fibroids. Yes, Dr. Amna, thank you so much. Yes. Guys, a biopsy is indicated for those who are premenopausal or perimenopausal when they are having something that's really fishy. This something is persistent intermenstrual bleeding. This woman is going to need hysteroscopy plus biopsy. Okay? The idea that there is intermenstrual bleeding means that we are having endometrial pathology. Okay, this is one of the most important indication and safe management also. Cervical lesions, you are going to do a biopsy because of a cervical lesion. What about the cervical lesion? You can do casco examination and you are going to see the cervix. If it looks suspicious, you can send her for colposcopy. It has nothing to do with a biopsy. Yeah, exactly. Yeah, colposcopy, not biopsy. Okay, great. Some of you said that having COC for 3 months and she's still having bleeding. Right? Don't judge any hormonal method before 6 months. In general. Okay, and we can change the method if the COC is not working. Yes, sure. Okay, you can see this one. I know HMB is a little bit tricky. Okay, so I'm going to focus on it. And let's see if you are good in contraception or not. What treatment will you recommend for a 33-year-old woman? HMB. On examination, the uterus is 8 weeks in size. Ultrasound showed 2 fibroids. One of them is 5, causing mild distortion of the endometrial cavity. The other one is 3. Her hemoglobin is 10.2. This should be milligram per deciliter. So I'm getting Mirena. Okay, so you are going to jeopardize inserting Mirena in a uterus with mild distortion. And the fibroid is more than 5 centimeters. Are you going to prescribe medical management for a patient who is having a fibroid 5 centimeters? The uterus is 8 weeks in size, guys. We're having a big uterus. And the patient is anemic. You know, this is not a single best answer. This is the only right answer. There is no way I would suspect giving her A, B, or C, or D. No way I'm going to give her gonadotropin-releasing hormone agonist, and that's it. She's 33. You can give her the GnRH analogs if she's going to have an operation. So yeah, we can try the GnRH analogs so that it's going to make the fibroid smaller, shrink it a little bit. But alone, for someone who is only 33, where are the HRT? This is not the best, of course. And you have this. You have this here. The UPA. If you are not going to prescribe UPA for someone who is in her situation, when you are going to prescribe it? I'm waiting for any objections. Forget about the numbers of questions. I don't care about how many questions we are going to answer today. I need to solidify some concepts. So tell me why you are not going to give her this or this or this inside your mind. If you still think about A or B or C or D, please tell me, I'm thinking about this, why I wouldn't give it to her. COC with a fibroid, 5 centimeters, it's not going to work. And it's not a recommended line of management in people who are having fibroids more than 3 centimeters. It's not a definitive treatment. It can be given until she's going to have the surgery. She can have tranexamic acid until having the surgery. She can have the gonadotropin releasing hormone until she's going to have the surgery. Yes, there was. But up to 4 courses, she can take it safely. And if she's having any liver condition, of course, you are not going to think about the UPA. This is why they limited the course of the UPA up to 4 courses. This is the most appropriate one between the options. None of them is definite. None of them. The definite treatment is surgery. None of them is definite. But this is not a transient line of management. UPA is not a transient line. UPA is a line by itself. Why not GnRH? Because number one, the patient is 33 years old. I cannot give her the GnRH agonist without giving her HRT. She's going to lose her bone density. Okay. And why not A or D? Because those are lines for treatment for those who are having fibroids less than 3 centimeters. Why not Mirena? Because the patient is having mild distortion in the endometrial cavity. They mention it for a reason. UPA is going to control her bleeding and decrease the size of the uterus also. Okay, let's see this one. This one, maybe it's going to make it more clear. This woman here, she is from Kenya and she's 40 years old. She's having difficulties in conceiving, HMB. Wow, she's 16 weeks uterine size. Ultrasound show multiple fibroids. The largest is 10 by 8, located in so and so. She's not keen to have surgery. And therefore, she has been offered either the gonadotropin agonist for 6 months or the UPA for 13 weeks. Those are the 4 courses. What advantage other than side effects does the GnRH agonist have over the UPA? By the way, this is a recall. Exactly. Exactly. The GnRH is having a very big effect in reduction of uterine volume, but not, of course, impact on fertility, and not because it's more effective or because of the duration of action is longer, or because it's stronger or anything. No. The main advantage is that it's going to reduce the uterine volume more than the UPA, especially in her case, very, very big uterus. Okay, the UAE. There's very great numbers of question marks around UEA. For some reason, most of the candidates, I don't know, they don't think about it within the management lines. So let's see, when should we prescribe the UEA? This woman with multiple uterine fibroids also. She has been offered various treatment options. She wished to have the UAE as she has completed her family, but would like to know the difference between this and hysterectomy. Look at the options. And forget about the options. You tell me, guys, why would you recommend her UEE over hysterectomy? And why would you recommend hysterectomy over UEE? Every one of them have pros and cons. Hysterectomy is a definitive treatment. Okay, so this is a pro. Okay. But if the answer why she's going to go for UAE instead of hysterectomy. No, it's not about this. It's not a must. She's asking you, I want to have the UAE. Okay, and you know that UAE is going to affect her fertility somehow. So they are telling you she has completed her family. What advantage UAE is going to give her over hysterectomy? Bear in mind, guys, that if you are going to do hysterectomy, this is a major operation. Okay, with great side effects and complications. No, number E is not correct. The minor complications with UAE is much bigger than hysterectomy. Major complications of hysterectomy are larger than UAE. UAE is going to need more and more interventions. Yes, further interventions. It's not going to be settled from one session. Not like hysterectomy, of course. Yeah, the best answer here is C. Yes, you were right. Yes. She's going to need further interventions within 2 to 5 years. But regarding satisfaction, UEA and hysterectomy or myomectomy has the same patient satisfaction. UAE, of course, is having more minor complications. Long-term effect, whether it was UAE or hysterectomy on the ovary, is the same. Okay, I know there's more and more HMB questions here. So what is the most common pregnancy outcome after UAE management for HMB? This is a recall, by the way. If I'm not wrong, it was mentioned in the TOG article. Spontaneous miscarriage or postpartum hemorrhage or cesarean section or malpresentation or FGR, all of them are pregnancy outcome after UAE. Which one is the most common one? Okay, I'm going to put my hands together for those who said hysterectomy, cesarean delivery, because this is something that I know it is like fire in the ground between groups. Okay, cesarean delivery guys have the greatest percentage, not the spontaneous miscarriage. Up to 67% are going to have cesarean delivery. Comes next, the spontaneous miscarriage. Okay, so if in the exam cesarean delivery was not there, yes, spontaneous miscarriage is the most common by far. Okay, great. So far we're doing well. Okay, so let's see this one. This lady is having dysmenorrhea, heavy periods, anemic, hemoglobin is 9. Ultrasound pelvis show 26 weeks size uterus with multiple fibroids. So most of you agreed that she can have the GnRH analog followed by hysterectomy. And I also agree, yes. So you got the idea of the single best answer? The single best answer means that you could be having 2 or more correct answers, but you have to choose the best of them. In the EMQ also, you are going to have multiple choices. When you exclude most of the incorrect options, you are going to be between 2 to 3 options. Again, you have to choose the best of them. Okay, let me make this in a separate page so you can see it now. A woman with abnormal uterine bleeding, she's 48. It has been 2 years. She tried mainly everything. COCs, progestogens, tranexamic acid, mefenamic acid, no improvement. She has 3 children, sterilized, lost cervical smear, normal. She had surgery for breast cancer 4 years before. Pelvic scan show no uterine abnormalities, but the size is 8 weeks of pregnancy and the endometrial sampling is normal. She's 8 weeks size, tried almost everything. and she's 48. So some of you are thinking about ablation, and some of you is thinking about hysterectomy. Okay, those who are thinking about hysterectomy, I'm having only one question for you. Are you offering her hysterectomy because she is sterilized? Okay. If it's so, I'm telling you, this is not correct. You shouldn't offer hysterectomy because the woman is sterilized. The uterus is not only for getting pregnant. Okay? Hysterectomy is a major surgery. So think about it like this. With major complications. So if I can offer her something safer than hysterectomy, this should be offered first. If she wants to have a definitive treatment, she said it like this, I want to have a definitive treatment, then yes, hysterectomy is the best answer. But guess what, guys? NICE guideline recommend that if you are having a lady with HMB alone, who is having a uterus no larger than 10 weeks, endometrial ablation would be preferred over hysterectomy. Why? Because it's safer. Why? Because it's effective. Why? Because the patient already completed her family. Endometrial ablation is great for this lady. This lady is a good candidate for ablation. Right? Because she does not need to get pregnant. And ablation is going to destroy not only the functional layer. We permanently destroy the functional active endometrial glands, okay? And up to 5 millimeters of the myometrium. So also the basic layer is going to be destroyed, not only the functional layer, and permanently destroyed. This is why endometrial ablation is not an option for someone who wants to get pregnant. And it's less invasive. It's an alternative to hysterectomy. Okay, so please put it in your mind. When you think about hysterectomy for some patient, think about offering her ablation first. Okay? If she said, no, I want to have a definitive treatment with no coming back, you can go for hysterectomy. Yes, I'm recording, right? Yeah, it's recorded. Don't worry. It's recorded. Okay, I want this question. I wish you haven't cheated the answer because this one is important. Okay, what would be the most common complication of UAE as a procedure, not its effect on pregnancy, not a pregnancy outcome? B, take care. They are saying higher rates of need of re-intervention when compared to MRI guided focused ultrasound. Yes, the most common side effect is pain and vaginal discharge. Excellent. This is one of the most important questions. This table is also very important. Okay, we have a guideline for UAE. This table is within this guideline. It's not a guideline, it's like best practice, I think. Yes, and post-embolization syndrome is not the most common, but it is the earliest, one of the earliest complications. Okay, but it's not the most common. The most common is vaginal discharge and pain, of course. Oh, I'm sorry. I have been talking to myself. Thank you, Dr. Omhanda. Okay, so this patient is having dyspareunia, severe nocturia, dry vulva and vagina. Everything is normal. All the biopsies are normal. Have you went through all options? You went through all of them? Okay, so the best way to answer EMQ is to have the answer in your mind and search for it. Sometimes you are going to find it, sometimes you are going to find a better answer. Okay, so you made your mind that this patient needs local estrogen, right? Vaginal estrogen. Because mostly those are urinary and vulvovaginal symptoms. So yes, guys, you are absolutely correct. Local estrogen is the best option here. Okay, let's have this one. This woman who is 50 years, she has been on COC since the age of 47. How will you diagnose menopause in this woman? And I have another question regarding this lady. I'm having serum FSH on 2 occasions, and I'm having presence of menopausal symptoms involving so and so and so. And I guess someone said, you know, all of you between D, 1C, 1A. Okay. I'm going to ask you a question so that you can make your mind again about the correct answer. Can we offer serum FSH for someone who is taking estrogen? Is it reliable? No. No. We are not going to use the FSH because it's not reliable. Estrogen, guys, in the COCs are very strong. They are going to cause negative feedback on the pituitary. So the FSH is going to appear normal. It's not going to appear high. This is why we don't rely on FSH for a woman who is above 50 or above, and also she's using CUC. No way. Can we use the FSH if she is using other type of hormonal therapy? Let's say she was using POPs before 50 for whatever duration. She is using POP or DEMPA or I have to be specific here. No, not DEMPA. She's using POP or implant, okay, or Mirena since she was 35. Now she's 50 and she want to know if she is menopausal or not. She want to make sure she can stop using contraceptions or not. Can you use FSH to detect if she is menopausal or not? Exactly. If she's using POP, Mirena, implant, yes, we can run the FSH to make sure she is menopausal or not. But if she was using DEMPA or COC, no, you cannot use the FSH. So what we are going to do? Only the presence of menopausal symptom is enough to diagnose menopause in this lady? Unfortunately, no. No. If she was not using any kind of hormonal therapy, I would say yes, definitely. Because she's 50. But because she's using COC, I cannot depend on the symptoms. You are going to diagnose menopause in this lady after stopping the HRT, and she's having amenorrhea for at least 2 years. 2 years. Normally, amenorrhea for 1 year is enough to diagnose menopause. But because she's having COC, she needs to have amenorrhea at least 2 years after stopping the HRT. Correct answer is this one. Okay. Yeah, I forgot to ask the other question. So I'm getting back to the question again. I have distorted the file. Anyway, so let's get back to this woman again. Okay, and this woman now who is using the CUC, she's 50, okay, and she's asking you if she can stop the contraception or not. And if you can stop it, what would be your advice? I can give you options if you want. She can stop it without having any other contraception. She can stop it and switch to POP. She can stop it and switch to barrier contraceptions. She can continue on the CUC. Number one, she cannot continue on the CUC because she is now 50. And it's very risky. Okay? CUC should be stopped by the age of 50. So I'm not going to continue. Number two, are we going to switch to POP or to barrier contraception? I would go for a barrier because I need to know if this woman is really menopausal or not. If she still have POP, we are going to be again in the eternal question, am I menopausal or not? When can I stop the POP? Yeah, she's going to continue until 55. But for a woman who wants to stop contraception, are you really going to switch her from COC to POP? No. So if you are going to switch, you are going to switch to a barrier. Someone is going to tell me why. She's menopausal. How I know? So again, the option of stopping any kind of contraception because she's menopausal is incorrect. I'm not sure if she's menopausal or not. And guess what? I have seen cases who got pregnant at the age of 50. So she's going to kill you, and maybe she's going to burn the whole hospital. This is the least thing that she's going to do. Okay, and I think this is better than suing you and taking all of your money. So please make sure she's menopausal first. Okay, guys? Once you are sure she's menopausal, yes, she can stop any kind of contraception. If she's taking POP, if she's taking Mirena, if she is taking the implant, okay, and she wants to continue using them, which is not preferable, by the way, okay, progesterone is not going to give her any advantage at this age, but she can still continue until the age of 55. Just wanted to make a point. Okay, so we were having here a question about PMS. Okay, let's take this one. This woman with severe PMS, how many years after menopause? For what? To use contraception. If she was already on contraception, okay, by 50, she should stop COC or DEMPA. But other methods can be continued until 55, by far. After 55, all kinds of contraception can be stopped safely, even without doing any kind of testing. Okay, why I'm answering this one? Yes, we are going to switch to barrier and wait for 2 years. This is when you are going to be sure she's menopausal and she can stop any kind of contraception. Okay, so as you can see, it is answered, but someone please tell me why I choose the low dose SSRIs for this woman. Severe PMS, excellent. Severe PMS. Yes, this is why. This is why here. For severe PMS, you are going to prescribe low-dose SSRI. Okay, and did you notice that they are bringing you some sentences that can ring a bell? like completed her family so that you are going to think about hysterectomy. Okay, she had tried CBT, she is a smoker, she is obese, and so on. Right? Okay, if you are going to prescribe the CUC for a patient who is having PMS, do you know what would be the first line in CUCs? This is a very common recall. Drospirenone, yes, drospirenone containing CUC. Okay, great. I love this question also. A patient who is Jehovah's Witness. HMB used hormonal and non-hormonal treatments with no effect. Hemoglobin dropped to 90 milligram per deciliter. I don't know why they are saying this. Anyway, a TVS showed multiple uterine fibroids, 3 to 12 centimeter in size. She wished to start her family soon and wants to avoid surgery. Yeah, because of the risk factors. Because of the risk factors, Dr. Aisha. So again, I got some answers between non-cyclical, oral contraceptions. Guys, for God's sake, she's having uterine fibroids 3 to 12 centimeters. And she already used hormonal and non-hormonal medical treatment. If we are having here hysterectomy, would you choose it? Forget about this. Forget about this. Would you choose it? Forget about trying to conceive. The scenario now is like this. Would you choose hysterectomy or UAE? Alhamdulillah. Thank you, Dr. Nabila. Thank you. Thank you so much. The patient is Jehovah's Witness. She's going to refuse blood transfusion. And hysterectomy, most common complication is, what is the major most common complication of hysterectomy? Bleeding. And this woman is going to refuse bleeding. So no way you are going to offer her hysterectomy. You're going to think about other alternatives. Right? So yes, UAE here is the best option, even if she wished to start her family soon. You would say that UAE is going to affect her chances to get pregnant? I'm going to tell you no. No, because we are not really sure how much effect UAE is going to be on her ovaries. Yeah, we are compromising somehow the blood supply to the ovary because of the anastomosis between uterine artery and ovarian artery, but she's going to get pregnant. The problem is she's going to have other side effects from the UAE on her pregnancy outcomes. Okay, why I'm saying so? It's very easy. If I remove this line, you are going to choose UAE simply. In the exam, you are going to think twice or 3 times And maybe after choosing the UEE, you are going to remove your choice and go for other thing, like blood transfusion or whatever. Okay, so the first thing that come to your mind is by far the best option. Okay, again here. This 53 beautiful old lady, she's amenorrheic for past 1 year, complaints of vaginal dryness, superficial dyspareunia, urgency. She has been treated for urine infection 2 months back, no active infection. She has been on HRT for the past 6 months due to severe palpitations, hot flushes, and night sweats. She is relieved of those symptoms. Which of the following is appropriate for her? Her symptoms are still there. The urinary symptoms are still there. Why? Yes, excellent, guys. So you know this very well. Yes. HRT, the systemic HRT, is not really good for urinary and vaginal symptoms. Systemic HRT is really good for vascular symptoms or vasculomotor symptoms. Okay, but if you are going to treat mainly urinary symptoms or vulvovaginal symptoms, you need to start local estrogen. Yes, excellent, everyone. So proud of you. Okay. This patient with no significant post-medical history. She's having vaginal soreness, dyspareunia, dysuria, atrophic vaginitis. She's commenced on topical vaginal estriol cream, reports marked improvement in the symptoms. What advice should be given regarding the use of systemic progestogens for endometrial protection? Yes, yes. Excellent, excellent, excellent. There is no need for endometrial protection. Local estrogen is not having a significant effect on the endometrium. Yes, and she does not need. Okay, if she needs, if she's having systemic HRT, what would be your answer here? Let me remove this. If this woman was on systemic HRT, what would be the best systemic progestin for endometrial protection? You know what? The best one, the one that you should offer as a first line for endometrial protection. Mirena. Yes, Mirena. Mirena is the best. But she can have oral progestogens. Yes, she can. Can she take it only in the second half of the cycle? If she's having withdrawal bleeding? Yes, she can. Can she take it continuously? Yes, she can. But this woman here, she's 63. If you are going to prescribe her HRT, which is better, continuous or cyclical? Continuous, yes, excellent. Excellent. So cyclical HRT mainly for those who are less than 50, right? Those who are having or in need for HRT because of POI or surgical menopause or ovarian suppression because of whatever reason. Continuous is better with postmenopausal ladies. Less side effects. Oh, great, guys. Okay. You know this by far. Okay. Let's see this one. You can maximize from your screen. The patient here, she's having PMS. She returned for follow-up after 2 months of completing a symptom diary, but the completed diary does not give a clear diagnosis. What treatment should be considered for 3 months to facilitate a definitive diagnosis? This is a very common exam question. If you are in doubt, or you don't have a clear diagnosis, or the patient, even after completing the diary, you are still not sure what type of PMS or even if it's PMS or not. Yes, GnRH analog for 3 months only. 3, not 6. For 3 months only. Okay, what are you expecting if she is a real PMS patient? What are you expecting after taking the GnRH analog for 3 months? Yes, you will feel better, exactly. So a positive, let's say this is like a test. A positive test would be resolution of the symptoms, right? If her symptoms persist, that means that she is PMS or not. No. No, she's not PMS. Okay, so you know this, or let's see. You are having otherwise healthy 30-year-old woman with PMI 24. She completed the diary, strongly suggestive for PMS, what would be considered the first-line pharmaceutical treatment option. I'm going to tell you why the eMRCOGs are tricky. See, who said the eMRCOGs are tricky? Dr. Zara? Can you see? Even your friends and colleagues here, they are having different answers for a question which is very clear. And I'm going to tell you why. When you answer a question like this eMRCOG, for example, I told you, have the answer in your mind first and search for it. After excluding all the incorrect options, you are going to be between 1, 2, 3 options. Choose the most typical one to the guideline. Exactly like what the guidelines say. So can we go here for COCs? Yes, but I'm having a better option. So they can give you combined oral contraceptive pills, continuous COC, cyclical, non-cyclical, and so on. But I'm having a better option here. This is the best. Someone who is going to tell me, why not CBT? This is going to happen in the exam. Make sure you have read the scenario very slowly. What would be considered the first line pharmaceutical treatment option. But CBT is correct? Yes. Got it, guys? We answered this one already. Yeah, and this is why they mention pharmaceutical. Or they are not going to put the CPT. CPT is not a treatment option, it's interventional option. So, because this is like a not really clear option, okay? So they are going to make it clear. CBT, by the way, is one of the lines that should be offered to all ladies with PMS. So some amenorrhea, let's have some amenorrhea questions. Those are just like the exam one. This woman with secondary infertility, secondary amenorrhea, some galactorrhea. On further questioning, she found that she has been on methyl dopa, and because she was diagnosed with preeclampsia and hypertension. Excellent. This is a drug-induced hyperprolactinemia. Exactly. So the treatment would be stop the drug. Okay, this woman who delivered a baby boy 2 years ago, she lost 4 liters of blood. And she mentioned that she had difficulty breastfeeding. Yes, this is a very, very typical Sheehan syndrome or panhypopituitarism. Very typical one. Sometimes it's not typical like this, by the way. So what do you think about this one? Okay, I'm having so many C's. Hypo, secondary amenorrhea, normal height, secondary sexual characters with BMI of 16. Yes, exactly. This is, it has a name. If you are going to classify this according to the WHO, this is type 1, type 2, type 3 amenorrhea. Yes, this is type 1 amenorrhea. Excellent. Okay, and it's because of her weight, right? Here in this one, this is very easy one. This is like a straightforward one. The patient here is having everything normal, but she's having a low PMI. This is why it has affected her pituitary. Not only her pituitary, affected her hypothalamus also. Okay, so this is WHO type 1 amenorrhea because of hypogonadotropic hypogonadism. Hypogonadotropic means that she's having hypopituitary now. No FSH and LH enough to stimulate the ovaries, the gonads, to secrete estrogen and progesterone. This is why she's having secondary amenorrhea, not primary. Okay, if she's having primary amenorrhea, okay, and again, she is 25. I wouldn't say 25. She's not going to stay silent all this long. She's 18. Okay, and the PMI is 16. With the same giving here. If you have to choose between those options, guys, what are you going to choose? So some of you have went to the MRKH syndrome. Others are thinking of hypothalamic hypogonadotropic hypogonadism. Okay, and I'm having Kalman syndrome. Okay, this can be exam question, by the way. So let's go through it one by one. MRKH syndrome. This is a correct one. I'm not going to say it's not correct. It's a correct one. It's a possible answer. And the hypothalamic hypogonadotropic hypogonadism is also a possible answer. Some of you went for Kalman syndrome as a hypopituitary or a hypogonadotropic hypogonadism. So I'm having three possible options here. Do you think they are stupid to make three correct options? No, they are not stupid. Let me tell you guys that in case of Kalman syndrome, her secondary sexual characters might be affected sometimes. This is number one. Number two, why they would mention the PMI in a case of MRKH syndrome or Kalman syndrome? Why this would be important? Or how you are going to make this in use? This woman is having very low PMI, very low. So now, after highlighting this, what would be the most appropriate answer? Yes. Her low PMI has nothing to do with the MRKH, has nothing to do with the Kalman syndrome. Okay, so make use of the information mentioned in the scenario. Sometimes, yes, there would be some sort of information to trick you or make you stray. But here we are between 1, 2, 3, 4, 5, 6, 7 words only. So make use of them. Here, yes, in case after I have changed a little bit here. So yeah, it would be hypothalamic hypogonadotrophy. Here, this 35 years old with secondary amenorrhea, the blood tests show FSH 39, LH 45. And I remember exam questions just like this. Very short scenario, no much details. Anyone have any idea other than premature ovarian failure? Someone would say I wouldn't diagnose POI with only one FSH. You are right. But this is what you have now. And definitely it's not anything else. Okay, here. This young lady, she is having inadequate breast development, amenorrhea, short stature. I'm not sure it's EMQ or not, so let's see. Let me show you all the options, yeah. A Turner would be the first thing that pop up in your mind. Yes, and you are very correct, yes. Don't think twice about something that you are really sure of. Forget about this, I'm going to change it. Okay, this lady here, she is 16 with normal breast development, primary amenorrhea, tall stature, 46 XY on karyotyping. You know, Dr. Sarah, when you are having a long scenario, it's much better than short one. When I'm having details, it's giving me a better or a clear picture about the scenario. I hate scenarios like this. I hate it. Because unfortunately, I'm a deep thinker. And it took me a long time to stop this habit. Okay, some of you went for androgen insensitivity syndrome. Okay, because she is XY. Right? Okay, I'm going to underline it. Okay, what else? Some of you said Swire. Okay, some of you said Kalman. Okay, Kalman syndrome and XY. If she is a male from the very beginning, why she would have a normal breast development? No way she is a Kalman syndrome. Kalman syndrome can come to males and females, yes. But in a male, he's not going to have a breast. So you are between AIS or Swire syndrome. Someone please tell me why I would choose Swire, not AIS, from the scenario. Both of them, the uterus is going to be absent, plus or minus. In AIS, definitely absent. In Swire, mainly, it's going to be absent. But from the scenario here, normal breast is a common sign in AIS and Swyer syndrome, complete AIS, of course. Tall stature. This young male, when he approached puberty, okay, he might find himself taller than all other girls, much taller than other girls. He's going to have a pelvis that looks like a female, wide pelvis, okay, but broad shoulders. Breasts could be normal and sometimes they are underdeveloped or small breasts. Small in size so that the physician is not really sure this could be familial or genetic, okay? But there is breast. It could be small, it could be normal in size, just small in size, with wide pelvis, okay? And the uterus and ovaries could be there, couldn't be there. Between literatures in Swyer syndrome, you are not going to find uterus. Okay, mainly you are not going to find uterus because he is XY. He's XY. Only some mosaic cases would have infantile uterus, but he does not have a uterus. He is XY, so no Mullerian duct. Instead of this, you can find remnants of testes inside the pelvis. Rudimentary testes. Okay, guys? In AIS, having a tall stature is not one of the phenotype of AIS. Again, use things that's mentioned in the scenario. So here, the best answer would be Swyer syndrome. Yeah. It could be another thing, but I'm not going to conflict you. Okay, what about this one? Not exactly. There are other syndromes that can give you a tall person, like LH receptor defect or insensitivity. He is a male, but the LH is not working. Okay, so again, he's going to have a problem with the testosterone in his body. But don't go to the receptor abnormalities because they are having various phenotypes. I'm having a lady, she is XX, normal genitalia, normal secondary sexual characters, uterus is absent. Yes, a very clear case of MRCOG syndrome. Okay, if I didn't say this. Okay, and let's remove this also. Would you choose one, please? Yes, thank you. Thank you so much. Yes, androgen insensitivity syndrome. Exactly. Okay, so after this, what would be the best next investigation? No, for this one, for this scenario here, the primary amenorrhea, normal external genitalia, secondary sexual characters are also normal, absent uterus on ultrasound. Karyotyping, yes, karyotyping. Okay, so let's get back to the other one. Here, why Kalman syndrome? Kalman syndrome is not going to have absent uterus. Kalman syndrome is a state of hypopituitary hypogonadism. She's having uterus, she's having ovaries, but the ovaries are not working because the pituitary is shut down. Swyer syndrome is very similar to complete AIS. Yes, I'm with you. But they are not going to have normal secondary sexual characters. Not normal like this. Not normal external genitalia. Okay, here, 46XX on karyotyping, and she's having absent uterus on ultrasound. What would be the best next investigation? No, they don't have. Not all of them. The pure Swyer syndrome does not have a uterus. She's XY. How she would have a Mullerian duct? Even if she has, it's not going to be a normal uterus. It's going to be infantile. Here, guys, this is exam question. If you are having MRKH syndrome, what would be the next best investigation? MRI? Why? Yes, to rule out the urology anomalies. What is the most common urinary tract anomalies in those ladies? Yeah, which renal? Yes, renal agenesis. Renal agenesis. Again, this is exam question. The most common one is renal agenesis. Okay. We are having another lady, primary amenorrhea, XX, normal, auditory problems. And this is a recall. Just like this, with some numbers of FSH and LH and so on. Excellent, Kalman syndrome. Kalman syndrome is not only about anosmia, they are also having auditory problems. Yes, excellent, guys. Excellent. Okay, I think it's time to go for some contraceptions. I want to know if you are good in contraception or not. It's not auditory problems in galactosemia. What would be there in galactosemia? Yes, visual, mainly visual. Okay, I think you're good so far, very good so far. Um, yes, exactly. Okay, I would go for some contraceptions. It's almost 2 hours. So let's go there. Please. Can we go for some surgery, then contraceptions until I open the file? I'm going to focus on injuries mainly. Okay. Surgery questions, guys, are not the questions that you should lose in the exam. You shouldn't lose those questions, honestly. Most of them are talk articles, I know, but please go through. Cesarean section, nice guideline. Reducing surgical skin infections, nice guideline. The enhanced recovery, the recent one, the recent talk article. Okay, the recent one is really like this, the previous one. They just mentioned some points about the same day discharge and so on. So yeah, I think that a question can come from this talk article also. But it is the same steps, same recommendation, everything. Okay, what else? We have a talk article regarding skin infections, also very important. We have a talk article about sutures and skin incision. Again, very, very important. Okay, so, and of course, the injuries, neural and vascular, and we have the third one, urinary tract injuries. So here we are having a patient, she's going for abdominal hysterectomy for HMB. She should be counseled that the following complication is rare. This is from the consent advice of hysterectomy. So what would be the rare complication within those? Consent advices are also crucial for the exam. So now we have an idea about the most common complication, which is bleeding or hemorrhage. A rare complication within those is bowel injury. Yes. The risk of hemorrhage and transfusion is almost 23 per 100. 23%. So this is a common complication. Bladder injury or pelvic abscess or pulmonary embolus, they are not rare. They are just uncommon. They are between 1% to 0.1%. Okay, 1 in 100 and 1 in 1,000. Okay, this is an anatomy question and it can be exam question, by the way. Sometimes, microbiology question, one surgical anatomy question. So, do you remember pelvic ureter? Okay. It descends on the pelvic side wall along the posterior border of psoas. So it is behind the psoas. No, it's anterior to it. Yes, the only correct one that it lies in the extraperitoneal areolar tissue because it's not supplied by the celiac branch of abdominal aorta. We are talking about pelvic ureter. Okay, it is the water under the bridge. It is inferior to the uterine vein and artery. And of course, it's not supplied by the saphenous nerve. Okay. The sites of narrowing could be exam question, but mainly for part 1. Here, we are having this lady who is having hysterectomy for fibroid. Regarding the course of the ureter, she is concerned because she's having adhesions and so on, or the side of the uterus is really big. Following the surgery, there is very few urine output despite adequate fluid intake. Which is the most appropriate investigation? This patient is having low urine output, or let's say in the exam they could be asking you that this patient is having anuria, or the bag is empty. What would be the most appropriate investigation? And I'm having a point bringing these questions to you. So if we are inside the surgery, during the surgery, and you are suspecting that you have hit the ureter, the ureteric injury, which one you would prefer from those? Again, the intravenous urogram from those. But if there is another option, I would go for it. There is another option that you can go when you are still inside the theater during the surgery. Something easier than IV urogram. Not cystoscopy. No. Cystoscopy is good for bladder injury during surgery. Yes, the best. So here, before we go for it, here the intravenous urogram is the best, of course, to delineate any ureteric injury after the surgery. During the surgery, yes, you can go for intravenous urogram, but it's not the easier, not the quickest. There is something quicker than this. I have it here. I know I have it here somewhere. No, not this one. Yeah, here. Using a dye where you are going to inject the dye. I'm talking about ureter, guys. Okay, choose from here. Choose from here. Forget about the scenario. I'm telling you, you are suspecting that you have hit the ureter during an operation, hysterectomy. okay? And you want to make sure if you really had a ureteric injury or not. Which one of those would be the best? Yes, yes, yes. Cesturestroscopy. Urestroscopy, not only cystoscopy. Cesturestroscopy. This could be done during the operation while you are still in the theater. Okay, so it's like see and treat. The urologist is going to be with you. He's going to detect the defect and repair it also. Okay, so here, this is another scenario. This woman, she had a TVT, okay, for incontinence, which we don't prefer right now. At follow-up, she is complaining of recurrent UTI and urgency to urinate. Her consultant wants to ensure there is no evidence of bladder wall perforation missed at her initial surgery. Yes, yes, Dr. Aisha, yes, thank you. I'm going to modify it. You want to know if there is a bladder perforation? Post-operative, which is the best modality. CT urogram or the hysteroscopy or ultrasound or IVU, intravenous urogram, or macturowating cystogram. Which is the easiest one to be performed? No risk of radiation, nothing. Here. No, not the ultrasound. Ultrasound is not sensitive. To detect a bladder wall perforation, cystourethropy. Whether it was intraoperative or postoperative, you can use the cystourethropy. It's just like hysteroscopy, but for the bladder. For the ureters, because Dr. Aisha mentioned something, so maybe I said it incorrectly or something. For the ureters, guys, either you are going to use the IV urogram, okay, or you know what is antegrade or retrograde pyelography? Yeah, this is what I'm making it clear, Dr. Nabila. I was thinking about the bladder, but I mentioned the ureters mistakenly. Cystourethropy is for the bladder. For the ureters, you need something to show you if there is a tear, a puncture, a lesion, a cut, or whatever. So let's say that this is the bladder, okay, and this is the ureter. Using the cystourethropy, you can see the urethra and the bladder. By far, you can see the opening of the ureters. That's it. To see if there is a lesion here, you should use retrograde or antegrade pylography. Okay, which we say it is the intravenous urogram. Intravenous urogram could be antegrade or retrograde. I'm sorry if I said ureters, and thank you, Dr. Aisha. You made me realize I was saying ureters, yes. Got it, guys? CT urogram, is it good? Yes, very good. Very good. But if I'm having something between like CT urogram and cystoscopy, which one is better? Which one you should choose first? This is less risky. CT urogram, you are going to have a dye. So there is a risk of radiation, contrast exposure. This is safer. If both of them was there for me to identify a bladder wall perforation, I would go for the cystoscopy. Okay, you know why? You know why? Because he mentioned that I need to exclude bladder wall perforation. This is different from another question that I know you have put in your mind. Another question like having a fistula, for example, vesicovaginal fistula, and you want to exclude that this patient is having fistula. Do you think that cystoscopy is a good modality to exclude fistula? No. No. CT urogram is the best here. It's going to determine where exactly the fistula is and how big it is. You got the difference? I can repeat. Okay, so think about it. Think about it. We are between either cystoscopy or CT urogram or IVU. IVU could be antegrade or retrograde. Okay, this is the intravenous pylography or urogram. Okay, this is a general term. Intravenous urogram is a general term. Inside the theater, while you are still in the operation, the easiest thing to do is cystourethropy. But unfortunately, it's not good for ureteric injuries. And this is why ureteric injuries are going to be discovered post-operatively. Okay? You got the difference? Okay, this one is easy one. Also, this one an easy one. Okay, maybe this one. Okay, this woman who is having worsening shortness of breath tachycardia 2 days after a radical hysterectomy, bilateral pelvic lymphadenectomy. Following initial investigations, CT, pulmonary angiogram demonstrate a segmental defect. What is the most appropriate next step? Yes, Dr. Dara, this is another modality. You can do the methylene blue test. But it's not investigation. This is a form of postoperative complication that can come in the exam. You should be aware when to prescribe thrombolytics, when to prescribe anticoagulation, when to perform further investigation. Remember guys, VTE in pregnancy, acute VTE in pregnancy, remember? When you only have a suspicion of VTE, only suspecting that this woman could be having pulmonary embolism because she's having shortness of breath, okay? And she is risky for the developing of any thrombi. You have excluded pulmonary infection, you have excluded cardiac causes. So what would be the next step? Do you remember? If you are just suspecting pulmonary embolism, are you going to run VQ scan or CTPA? Yes, thank you, Dr. Haifa. Yes. You are going to start therapeutic low molecular weight heparin until proven otherwise. And this is what you should do for any other human being. Not to mention that here the CTPA demonstrated already a segmental defect. What are you waiting for? The question now, should I give anticoagulation or thrombolytic therapy? No, actually anticoagulation. We reserve this thrombolytic therapy for those who are having compromised oxygenation. Okay, so here anticoagulation, if she's having hemodynamic instability or she is severely compromised, like the PO2 is less than 94, so yeah, I would go for thrombolytic therapy. But here, I'm still not having a definite diagnosis that this segmental defect is a thrombus. So we are going for anticoagulation, okay? And then if we are really sure, we are going to continue on the anticoagulation. Therapeutic, of course. Okay, let's revise some of the nice recommendation for reducing surgical skin infection. What would be the most appropriate pre-operative step to prevent surgical site infection in a 40-year-old woman undergoing total abdominal hysterectomy? Choose one of those. This should be very easy one. I'm having A and B and C. MashaAllah. Okay, so we do nasal decontamination to target Staph aureus for all patients? Do we do this for all patients? No, it's not a routine step. Okay, we only do it for those who are known to be carriers or they are having MRSA. Okay, okay. To shower before surgery, yes, okay, and have no bowel preparation, I agree. To shower before surgery, to have nasal decontamination, no, I don't agree. To shower before surgery, to take bowel preparation for our surgeries, gynae surgeries, is not a must. It's not a must. Okay? We don't do bowel preparations for our surgeries. To remove the hair via shaving, if you option to remove the hair, which is not routine, it's not a routine step to remove the hair. Are you going to do it by shaving or by a clipper? By a clipper. A single-use clipper would be the best, of course, ideal. But not by shaving. Shaving is going to leave you small abrasions, which is going to be susceptible site for bacteria. It's going to inhibit bacteria. So even if you option for shaving, hair removal, it's going to be by a clipper, not shaving. Bowel preparation is not a must. Showering is a routine step. Let's have a look here. See, guys, this is like crucial. And the enhanced recovery program, of course. So, of course, using aseptic non-touch techniques and so on, but someone please remind me, are you going to use different scalpels for the skin and the pelvic dissection or the same scalpel? According to NICE, there is no need to use different. Yes, no need to use different scalpels. Are you going to open the skin with the scalpel or by diathermy? Scalpel, yes. Are you going to clean wounds up to 48 hours after surgery by saline or by tap water? Saline, yes. Do we need to clean the wounds, which is healing by primary intention, by any kind of antimicrobial agents like pethidine? No. Do we use something like gauzes or mercury antiseptic solution to manage surgical wound healing by secondary intention? No. If it's healing correctly, if it's not infected, no need. No need to use gauzes or mercuric antiseptic solutions or any kind of antiseptics. Only use appropriate dressing. Appropriate dressing, sometimes you can use a dry dressing or a wet dressing. That's it. According to how the wound look like. Okay, but there is no need for any antiseptics. Okay. What else? If you are having a wound healing by secondary intention and it's not infected and there is no overhealing, okay, there is no overhealing, there is no infection, the wound look pinkish, everything is good. Do you need to do debridement? Do you need to have silver nitrate? This is a recall, by the way. It was a perineal wound. No need. When should we use silver nitrate for wounds? When there is hypergranulation tissue. Okay, so you are going to do cautery by the silver nitrate. When are you going to do debridement? When you are having dead tissue, necrotic tissue. This is what debridement means, removing the dead tissue to let the healthy cells multiply and make good secondary intention or good granulation tissue, I mean. Okay, this was exam question. I think the options were between chlorhexidine or sterile saline or tap water, something like this. Okay, so up to 48 hours, you are going to use sterile saline. After this, you can shower safely. You can use tap water safely. Okay, especially if the wound is open or separated, or it can drain by a drain. There is a drain. Okay, there is a drain or surgically open to drain pus. This is different, by the way, from general surgery. So don't conflict everything together. This is for our practice. Whether it was cesarean, abdominal, or something in the vulva or the vagina. Okay, what about antibiotic for reducing the skin infection? When should you give antibiotic, guys, before the surgery? Where are you? By the time of anesthesia induction, which is approximately 1 hour prior to skin incision, this is when the antibiotics should be commenced. Okay? After the operation, antibiotics are recommended for prolonged duration, not for all patients. Not for all patients, okay? Redosing is recommended in very special cases. Like if the surgery is prolonged, the blood loss is more than 1,500, the patient is morbidly obese, if the patient is having gynecological surgery, I mean, and she's having cardiac condition, she's having valve or transplant, but not for all patients. A prolonged dose is not recommended. Okay, what else? If the patient is going to have ovarian cystectomy or diagnostic laparoscopy for endometriosis, do you need to recommend antibiotic prophylaxis or not? No, no need. Okay, excellent. Just wanted to make sure that you know this. Okay, we have also, this is from, of course, this is a part of the enhanced recovery program. How would you reduce the risk of SSIs or surgical skin infections? Antimicrobial prophylaxis, as we mentioned, skin preparation. Skin preparation, are you going to use water-based chlorhexidine or alcohol-based water chlorhexidine? Alcohol-based, yes, alcohol-based chlorhexidine. Okay, avoiding hypothermia and surgical drains as much as you can, reducing intraoperative hyperglycemia. Those are the elements of the bundle. This could be exam question by itself. We have also this, I don't love it. It's a talk article talking about the acute colonic pseudo-obstruction. Mainly, they are going to bring you a case where there is absent bowel sounds. She's having distension. The pain is not really great. She's having mild abdominal pain, okay? Which is, yeah, the second day of the surgery. Second day of the surgery. This is mostly ileus. This is mostly ileus, paralytic ileus. When the pain is really severe, the distension is really marked, and there is minimal flatus or stool, and the x-ray is going to give you the same picture, by the way, and usually it's going to be very early. This is the acute colonic pseudo-obstruction. The cut-off sign is very pathognomonic for it. Okay. VTE prophylaxis also is very, very important. One dehiscence, this is what I was talking to you about. No, not this one. Okay, we can get back to the question. Okay, a woman who just had a total abdominal hysterectomy and PSO, she developed pyrexia 12 hours after surgery. No other symptoms. What is the most likely the cause of her pyrexia? Yes, pulmonary atelectasis by far is the most common cause of post-operative pyrexia in the first 48 hours, mostly 24 hours. Keep it in mind. Wound infection is very late. Urinary tract infection are very late. The thing that could be a possible reason, but after 48 hours, are pulmonary infections or chest infections. Okay, this one is really great. It depends on the talk article also. The VTE in gynecology preventing VTE in gynecology procedures. For at least how many weeks should COC prior to major surgery be postponed? COC or this is old. This is old because this is answer of strategy. HRT can be continued. It should not be stopped before surgeries. You can consider it before major surgeries, but in general, it should not be stopped. But COC should be stopped 4 to 6 weeks prior to major pelvic surgeries. Okay. Yeah, let's have a laparoscopy question. Which of the following techniques should be employed to reduce entry-related laparoscopic injuries when performing a diagnostic laparoscopy? Trendelenburg tilt is only done after insufflation. Yes, horizontal positioning of the patient at first. Yes, exactly. This is the correct answer. And of course, the varus needle should be sharp. The Trendelenburg tilt and insertion of varus needle at right angle is definitely wrong. You should insert the varus needle at right angle first in horizontal position, insufflate the abdomen, then do the Trendelenburg tilt. Varus needle should be moved laterally to check if it's free before gas insufflation. Definitely no. Definitely no. Okay, we are not going to move the varus needle laterally. No, no way. After gas insufflation, you are going to insert the camera and make sure that everything is okay, nothing is punctured, nothing is injured. Okay, this is a very, very famous scenario. Let me make it short for you. This patient here, she is having previous 2 cesarean sections. And she's having 4-hour history of severe left side lower abdominal pain, positive urine pregnancy test. So they are suspecting that this is ectopic. She gives a history of splenectomy as a child. Anyway, they are going for laparoscopic surgical management of ectopic. The woman here is having 2 failed attempts to insert the varus needle through the umbilicus. What would be the next step to achieve laparoscopic entry? Okay, so yeah, one of you choose the palmar point. There is a contraindication to choose the palmar point in this case. Yes, she had done splenectomy. So you are expecting adhesions in the palmar point. So we are not going to use the palmar point. We're going to use the open Hasson technique, which is not famous in our practice. We usually use the Palmer point entry as an alternative for the varus needle. Exactly. But here, because she is having splenectomy, I'm going to do X on the Palmer point. This one is not our best option now. Okay. So far, guys, I'm really proud of you, wallahi. Okay, I hope we have a more time, but I'm going to be honest with you. I have another session, so we are going to end our discussion for today. And I'm going to take votes for the upcoming discussion. If you want to have other questions regarding gynae with our next discussion, it's okay. We need more and more discussions, honestly. Okay, definitely, definitely. I'm going to send a PDF so that you can see all the questions. Okay, take care, everyone, and thank you so much for attending. Thank you, dear. Ramadan Mubarak. Have a nice day. I'm not going to forget. To the WhatsApp group, inshallah. And to the Telegram group, it's okay. See you soon, everyone. See you next week. Stay safe. Assalamu alaikum.